Hello everyone, welcome to podcast 13 of Let's Revise MBBS, and today's topic is ectopic pregnancy. So what is ectopic pregnancy? Basically, as the name suggests, it is any pregnancy which occurs outside the uterus or outside the endometrium. Okay, it can occur in fallopian tube, in ovaries, anywhere, but it should be outside the endometrium. Okay, so before starting the topic in detail, first I would like to tell you some one-liners which come as direct MCQs. Okay, so which is the most common site of ectopic pregnancy? It is fallopian tube, right? Because endometrium and fallopian tube have almost similar lining, not exactly, but yeah, somewhat it matches, and the fertilized ovum comes from fallopian tube to the uterus. So anywhere in the fallopian tube it can get implanted. So the most common site is fallopian tube. The least common site is the scar of the cesarean section. Okay, that is the least common site. Okay, now in the fallopian tube we have four parts. Which are the four parts? Let's start from medial. Most medially we have interstitium. Okay, then we have isthmus. Then we have the largest portion, that is ampulla. And finally, lateral most, we have infundibular end, or we can also call it fimbrial end. Okay, so these are the four parts of fallopian tube. What do you think is the most common part to have ectopic pregnancy? It is ampulla, right? Why? First, because the fertilization occurs in the ampulla, and second, because it is the largest part of the fallopian tube, longest also, right? So ampulla is most common. Then after ampulla comes isthmus. Okay, after isthmus we have infundibular end, and last or least common site in the fallopian tube is interstitial part, right? Now, tell me which, if the pregnancy occurs in fallopian tube, then the tubal rupture is most common in which part of these four parts, ampulla, isthmus, infundibulum and interstitium? Which is the most common part to get ruptured? Right, it is the isthmus. Why? Because it is very narrow. Isthmus is very narrow. So even if the embryo or the fertilizing when the ovary when the zygote is implanted, when it starts increasing in size, at 6 weeks it can rupture the isthmus portion, right? Now, so if I ask you one more question, that ectopic pregnancy to end earliest in the fallopian tube will be, so the answer will be same, isthmus, because it gets ruptured the earliest, and therefore the pregnancy will end in the isthmus the earliest. Okay, now the next question is, in which part of the fallopian tube will the ectopic pregnancy last for the longest time? Think. See, the answer is interstitial part. Why? Because even if the interstitial part is narrow, but medial to the interstitium we have the uterus, the large cavity of the uterus. So the embryo has a large area to grow, and therefore the pregnancy in the interstitium will last for a very long time. Okay, and the chances of rupture are less in interstitium because it will expand in the uterine cavity, right? And if I ask you which is the ectopic pregnancy which lasts longest, not in the fallopian tube, overall. So think that where do we have huge space? Where does the embryo or fertilizing zygote has a large space to grow? It is abdomen. So abdominal ectopic will survive for the longest time, right? Now let's come on to the risk factors. Okay, so there are basically 2 points here: the most common risk factor and highest risk factor. Okay, so most common risk factor is PID, pelvic inflammatory disease, and highest risk factor is previous ectopic pregnancy, right? Why it is not the most common? Because ectopic pregnancy in itself is rare. So ectopic pregnancy cannot be most common risk factor for ectopic pregnancy. It will be the highest risk factor. Okay, and PID is the most common risk factor. Why? Because in PID there is inflammation going on, then the motility of the fallopian tube, ciliary function, everything will be disturbed, and therefore there are more chances of ectopic pregnancy. Now how will the patient present? What will be the symptoms of ectopic pregnancy? So basically there is a triad of pain in abdomen, amenorrhea and bleeding per vagina. So pain in abdomen, why is there pain in abdomen? In case of ruptured ectopic, obviously there will be pain because there is hemiperitoneum. This hemiperitoneum will stimulate the diaphragm, and it can also, there can be shoulder tip pain because of the common nerve innervation. And if the ectopic pregnancy is not ruptured, it will stretch the fallopian, if it's in the fallopian tube, because that's the most common site. So if it stretches the fallopian tube, there can again be pain. So pain in abdomen is the first symptom. Second symptom is amenorrhea, obviously because she is pregnant, right? So she'll have a history of amenorrhea for around 6 to 10 weeks or even 12 weeks, and there can be bleeding per vaginum because of shedding of the decidual cast. Okay, because deciduum is growing in the uterus, but there is no pregnancy in the uterus. So this cast will be shed out. Therefore, there will be bleeding. So this is the common triad which we see in the ectopic pregnancy. Now, how to diagnose? First, we'll have to confirm that she is pregnant. For that, we will do UPT, urine pregnancy test, and confirm that she is pregnant. Then what will we do? We will do USG. On USG, we will see ring of fire appearance, and we will also look for gestational sac. If we see gestational sac outside the uterine cavity, then it is ectopic. It is confirmed that it is ectopic. Okay, but if we do not see gestational sac in uterine cavity, and we are also not able to see gestational sac in anywhere else, like we are not able to see gestational sac in fallopian tube or in the abdomen, then what will we do? We don't know whether it's ectopic pregnancy or it is aborted. So for that, we check HCG levels. Okay, if gestation sac is not seen, we check for HCG levels. If HCG levels are more than 2000 and they are rising, the levels of HCG are going on increasing, then we can diagnose it as ectopic pregnancy. See, suppose I do beta HCG level today, it comes 2000. After 48 hours, it should double. The level of beta HCG should double if it is intrauterine pregnancy. Okay, so 2000, if it becomes 4000, then it is not ectopic. It is normal intrauterine pregnancy. If from 2000 it increases to 2500, then the pregnancy is still there, but it is ectopic. And if I do today it's 2000, 48 hours later it becomes 1500, that means it's aborted. Abortion has happened. Okay, so by the checking beta HCG level, we can come to a diagnosis that whether she is having ectopic pregnancy or not. Now let's come on to the management of ectopic pregnancy. So ectopic can be either ruptured or unruptured. Okay, so how will you let's talk about a ruptured ectopic. So ruptured ectopic patient will mostly present with shock, right? Because there is internal bleeding going on, blood volume will decrease, and she will present with shock. Rest all the other symptoms which we talked about, the triad, will be present. Along with it, shock will also be present. So this is an emergency. There is no role of medical management in ruptured ectopic pregnancy. We need to intervene surgically, right? But before going to laparotomy, we first resuscitate the patient. We give her fluids, and when her vitals are stable, we take her for laparotomy. So we have two options: laparotomy, laparoscopy. Laparotomy is preferred because laparoscopy we need a very skilled surgeons, and it's slightly time consuming. Laparotomy is we open, we find where is the rupture and we correct it, right? So laparotomy is preferred. So after doing laparotomy, what we do is we remove that portion of fallopian tube which is ruptured. So we do salpingectomy, irrespective of anything, whether the family of the patient is complete, whether she is nulliparous, multiparous, nothing. We will just remove that portion of fallopian tube because we want to save the patient's life. Okay, we can't say that she is nulliparous, so let's try to preserve this fallopian tube. No, we have to save the life. So we removed that part of the fallopian tube which is ruptured, and we anastomosed the remaining two parts. Right. Now let's see about unruptured. So unruptured pregnancy is mostly managed medically. For medical management, we give methotrexate. Now we have two regimes: single dose regime and multiple dose regime. So single dose regime is most commonly followed. Let's see about single dose regime. So what we do is, on day 1 we give her methotrexate. Okay. Then we wait for 2-3 days, and on day 4 we check her beta HCG levels. Okay, and again on day 7 we check her beta HCG levels. So day 1, 4, 7, 147. Remember, day 1 give her methotrexate, day 4 check beta HCG, day 7 again check her beta HCG. If the drop in beta HCG is more than 15%, then ectopic pregnancy is getting aborted. Right? So if on day 4 we get beta HCG level as 4000. Okay. So what is 15% of 4000? So 4000, 10% is 400, 5% is 200. So 600. 15% of 4000 is 600. So on day 4 you get beta HCG level as 4000, and on day 7 you get it as 3400 or less than 3400. Then you stop methotrexate and it will eventually get aborted. Okay. If it doesn't happen, you repeat the same. You give her methotrexate again. On day 4 you again check HCG level, and on day 7 you again check if the difference is more than 15%. If it is more than 15%, then stop methotrexate. If it is not, again repeat for the last time. For the third time, repeat the same thing. Okay. And even after this, the beta HCG level do not decrease by more than 15%, then you need to go for surgical management. Okay. This was about single dose regime. Multiple dose regime, what we do is, on day 1, 3, 5 and 7 we give methotrexate, and on day 2, 4, 6 and 8 we check her beta HCG levels. Okay. And anytime if the beta HCG level drops more than 15%, we stop the regime. Okay. Now let's see about surgical management of unruptured ectopic. Now you tried methotrexate for 3 times, it didn't work. We go for surgical management. In surgical management, what we do is salpingostomy. Okay, here we go for laparoscopy because the patient is stable. No emergency is not there, so we go for laparoscopically. We do salpingostomy. What is salpingostomy? Stomy is opening. So we open the fallopian tube, remove the ectopic, and leave it as it is. We do not stitch it. We do not suture it, because if we suture it, the chances of second ectopic are high. Therefore, we leave it open. The body will heal itself. Okay, so that is surgical management of unruptured ectopic. So yeah, there are three important points which are just names. So there are some like how to diagnose ectopic pregnancy at other sites. So if it is abdominal ectopic, cervical ectopic or ovarian ectopic. So there are various criterias. I'll just tell you the names. Okay. So if there is abdominal ectopic, we use Study-Ford criteria. So abdominal has D in it, Study-Ford also has D in it. So remember, abdominal ectopic, Study-Ford criteria. Cervical ectopic, we have Palman criteria and Rubin criteria. So CPR. Cervical, Palman criteria and Rubin criteria. And ovarian, for ovarian ectopic, we have Spiegelberg criteria. So ovarian and Spiegelberg. Okay, so yeah, remember this one, ovarian and Spiegelberg. Rest two, I told you a mnemonic to remember. So you just need to remember these names. They can ask you in MCQs. Baki, you don't need to remember what is there exactly in the criteria. Right, so that's all about ectopic pregnancy. See you in the next podcast. Till then, enjoy and keep studying. Bye.